Hi everyone. Welcome to this final session of the final kind of breakout session of the conference. If this was a face-to-face conference, this would be the point everyone would be sitting there with their luggage ready to walk out the door. But hopefully you've got enough energy to have listen to one more set of presentations. I've said a couple of times in different places that social prescribing is the most evaluated thing of the 21st century. I'm not sure if that's statistically true, but it's certainly had lots of evaluations done recently, and it's really great to be here in this session to kind of hear from some of the more recent up-to-date evaluations that have been happening. So we've only got a short session, so I'm going to kick us off and hand over to our first presenter. They've each got about 6 minutes each, and then there'll be plenty of time for questions at the end. So our first presenter is Professor Gina Yannitell from the University of Essex, talking about the evaluation of the LifeLink program. If you want to share your screen and get started.
I would love to. Let's hope this works. Can you see that?
We can, yeah.
I'm so glad to hear it. Okay, hi everybody. Thanks for coming to our breakout section. And thanks also for the introduction and to all the panelists for joining me with this. My name is Gina Yannitell Reinhardt. I'm a professor at the University of Essex, and I represent in this context a project called Connected Communities, which is funded by the European Commission. It exists along the English Channel, so it involves local authorities in the east of England and also in Normandy and France. We are in charge of evaluation, dissemination, and integration of the project at the University of Essex. And as part of that group, we teamed up with a group in West Suffolk, which is not actually one of our local authority partners, but they are offering a social prescribing program called LifeLink. And their first part of their program was a pilot in the Haverhill region that had very particular aims to link people with support groups, generate new motivation and interest among participants, signpost to employability and learning opportunities, give coaching regarding a healthy and active lifestyle, and link people with appropriate debt benefits and housing support. This pilot opened up with two particular GP surgeries. They were both at capacity and under pressure. Haverhill has no hospital or walk-in clinic, and access to secondary services are limited for residents. Transportation is costly and limited, and Haverhill had at the time, the highest long-term unemployment rates in the county of Suffolk, as well as including anyone in Norfolk or Cambridgeshire, so very high levels of deprivation. They opened the services to anyone age 16 or older who thought themselves to be or was judged to be socially isolated, low in mood, low or higher levels of anxiety, feeling they had poor life skills, managing a long-term health condition, managing mild to moderate learning disabilities, or just simply wanting to be more connected. And they rolled out or began to offer the LifeLink program in 2 phases. It's important that we distinguish between these phases because during those phases, the measurement metrics and the evaluation metrics actually changed. In the pilot phase, they relied primarily on asking the WEMWEBS questions, well-being questions from Edinburgh, as well as a few other measures. But in the second half, when the pilot was extended to a few more areas, they relied strictly on patient activation measures, the PAM, as well as the ONS target 4 questions that the UK requires for social prescribing programs to ask. Whoops. So we examined the responses that participants gave to a certain set of questions between before they entered the program and after, or as they were leaving the program. And some of the questions they answered pertain to 6 months prior to the program as they entered it. So over the 6 months period following participation compared to the 6 months prior to participation, it was determined that attendance at the GP surgery went down an average of 0.86 visits per person, or you could say an average of 4 visits over 5 months. This data was actually gathered from the GP surgeries themselves. So this is not people's interpretation of their GP visits or their memory of GP visits, but this is actually the number of visits they had to the GP. That's a statistically significant difference. The scores of well-being from the WEMWebs improved by 2.85 points. The patient activation measures improved by 0.5. People's optimism about the future improved by 0.24 points. Their interest in new things improved. Their feelings of being able to make up one's mind about things improved. These are all statistically significant changes across the sample. And there were some other improvements as well. There were some things that did not change significantly. Those were alcohol consumption, smoking, exercising, illicit or recreational drug usage. Prescription drug usage as well was not documented to change, as well as diets and, importantly, secondary care. So a lot of times what we're seeing sectorally speaking and in the system is that people are not going to the GP as often, but they are instead increasing their visits to more targeted non-GP clinicians such as nurse practitioners or A&E or physio. And in this case, those events, those visits did not appear to change. We do have some qualitative evidence as well from a random sample of case notes that we audited. People were initially skeptical about these one-to-one sessions, which I think a lot of people are, and we've been learning that over the few days, but immediately people report being put at ease, having very good relationships with their social prescribers. Apparently my time is up according to my little bells, but let me just wrap this up as quickly as I can. So if we give a cost to a GP visit based on what the King's Fund tells us a GP visit costs, the overall reduction in GP usage gave us a total potential cost savings worth over £3,500 over phase 1. The improvement in well-being scores using the well-being scores measures of the cashable social benefits was worth roughly £3,800 per participant who had 2 or more meaningful LifeLink appointments. And the overall benefits across the system, therefore, were about £3,900 per participant with 2 or more meaningful appointments. In the end, that actually became estimated to several £1,000,000 based on the number of participants. We don't actually share that figure widely simply because the sample was voluntary, the sample was particularly chosen in a particular way and has some selection issues that I'm happy to advise about or discuss. However, another issue that came up was the data collection protocol, which Haverhill and West Suffolk are working on making consistent in different phases. So I had to rush that at the end, but I'm happy to answer any questions about it. Thanks very much, everyone.
There you go. I was muted then. Thanks. I was saying thanks, Gina. I think what I've asked everyone to do is put some questions in the chat, and then we'll try and have a kind of a consolidated discussion at the end, if that's okay. I'm now going to hand over to Helen Seers, who works really closely with Marie Polley on a number of evaluations and things. And I remember having some conversations with Helen and Marie when they just started this evaluation. So I'm really interested to kind of hear what the findings are. Thanks.
Thank you, Chris. Can you hear me and see the slides all right?
Yes, we can. Yeah.
Hello. Yeah, I'll try and be quick as well. And it's nice that Chris is chairing this session, because you're right, you did talk to us about this and advise us on this. So I'm just going to talk to you from my little slot here about a piece of work that Marie Polley, Rachel Johnson and I did 2020, 2021. And it was a piece of work by Marie Polley Consultancy, and it's an evaluation of social prescribing service in Surrey. I'm going to look at the context of this service, who used the wellbeing prescription service, what referrals were made, what outcomes were collected, and then looking at the impact of COVID-19 and moving forwards. And I just want to say hello to any of the people that are from the Wellbeing Prescription Service that are maybe on this call just now, attending the conference. If you're here, hello, and we recognise the hard work that you put into this work and this service. So I hope the evaluation does it justice. So we were commissioned by Tandridge District Council to do this evaluation, and it was in line with their Surrey Health and Wellbeing Strategy, a 10-year wellbeing strategy. And the wellbeing prescription service at the time of us being commissioned was about 5 years old, and it really had a lifestyle kind of a reason to support people with their lifestyle. But this was evolved and broadened in terms of its reach as the service progressed and developed. The service evaluation that we were commissioned to do happened at a time of great change in this country. The data that we collected spanned the before and during COVID times. So it was a very interesting piece to do. We had access to the Elemental software platform, which was kind of pioneering the data collection in this area. The project also did interview 15 stakeholders. I can't present that data here, I haven't got time. But the data I'm going to present is about the actual service itself, and it was broken into a standard service for kind of the normal age population accessing social prescribing, and a plus service for older people. So the basic demographics, there were 3,500 users nearly that we had in our data sample. The basic demographic, the modal person was female and white. But when we looked at the standard, the normal kind of service, those guys were younger, living together and more likely to be employed. But the older service, for the plus service as we describe it, those people received home visits, and they were obviously older. They lived alone more likely, and they were retired. And this graph just shows you that obviously that plus group were older. So you can see those grey bars are in the kind of 75 plus. Interestingly, the disease profile for the older group was more kind of COPD, dementia, stroke, but for the kind of normal standard group, it was more lifestyle related, like blood pressure and diabetes. So why would people refer to the service? There's a satisfied customer quote saying that it helped them. I probably haven't got time to read it, but there you go. And who referred? GPs did the referrals, but self-referrals happened. And why were people referred? Well, the standard group, they were referred for lifestyle reasons, and the older group, they were referred for maybe more emotional, social isolation reasons. So there was a difference. What prescriptions were made? Well, the referral reasons were lifestyle in general. This is for the whole group. After the link worker conversation, the prescriptions that were actually made were different. They echoed more wider reaching things, and perhaps this is because the conversation with the link worker has that more rounded situation where you're looking at causes of health and wider social determinants of health. So onto the outcomes data. What did we actually find? And I'm sorry if this is a whistle-stop tour of the work. This is for the kind of younger age group. This was the lifestyle data that was collected, and like the previous presentation, we did find some good outcomes. We found weight, physical activity, mental well-being, and alcohol risk were all significantly improved, and clinically significantly improved as well. And just at the bottom on the left there, we did find, like the previous piece of work, a 0.7 reduction in GP visits over 6 months for the sample. So this again was statistically significant and showed that it was making a difference. We could not follow this up during COVID times because people didn't go to the GP like they did. So that was a limitation. But overall, the data was very strong. For the older group, for the plus group, we only had data available for the MyCore tool, which is a tool close to Marie, Polley and my heart, which is the tool that we look after in our other work. MyCore collects qualitative and quantitative data, and it looks at people's concerns and well-being. This data for the older sample was very strong. It showed significant change in the right direction, and the overall profile score showed that 72% of people in this older group had made a clinically relevant improvement to their well-being overall. But unfortunately, this sample set was slightly small, and you can't really generalize it to the whole of the population because data was difficult to collect. The MyCore data, just to break that down, because you get a nice bit of qualitative data out of it, it breaks down into the reasons why people wanted to have help. And these, for the older group, were psychological things like loneliness, practical concerns. Interestingly, it was things like helping with computers and digital access. That did come up, which was interesting. Well-being concerns about loneliness and physical concerns, mobility and, weight change. So there's a lot more to unpack, and you can read all of this in the longer report. Just to kind of get to the kind of COVID bit, this quote just kind of emphasizes about deconditioning and people, not being able to move around, and in that older group, it becoming a health hazard of falling. The impacts of COVID on this service, well, referrals did carry on, but obviously not face to face. But the service did respond very, very well and quickly adapted. Information flow was challenging, but new channels opened up and new working environments occurred. And data collection for the evaluation was curtailed, but I think we can all understand why. People were more isolated, and there were less services to prescribe to, obviously, but the link workers did step into a broader role and support them. Digital provision of the services and support was well provided, but it was challenging, and some people did not want to do video calls and things like that. And just to refer to a nice piece of work done in 2020, this explores the evolving role of the link worker during the COVID pandemic. This was a piece of work done by Marie, Polley and I, and that's just something nice to refer to there. It's kind of another model. Again, that's in our report. So just to conclude, and I hope I'm keeping to time. So the wellbeing prescription did support the aims of the Surrey Health and Wellbeing Strategy. So it ticked that box. The service provision was wider than the original lifestyle remit. It evolved over time and expanded even more in the pandemic. The wellbeing prescription service, it showed a very well organised team. It was flexible, collaborative, worked really well with the voluntary sector and PCNs. It really was very dynamic, and it did improve efficiency in referral pathways, and digital provision improved. It was a lot of hard work from these guys. The outcomes data was good where we collected it. It showed that lifestyle improved, it showed mental health improved, it showed reduction in GP visits. And also in the older group, we showed that the MyCore concerns and wellbeing improved. So it was a very good first look at this, and we did advise the service on streamlining its outcomes and how to improve follow-up data collection. And the data collection was curtailed by COVID and just those circumstances, but we're confident that moving forwards with the streamlined data collection and less burden on people, more data is being collected. And yeah, we do know that from all of the talk within the project to the stakeholders, the wider stakeholders, it was very satisfactory. So I'm sorry if that was a quick run through a very detailed piece of work that we did. It's available. I have tweeted the link on my Twitter to the whole report, or you can email Marie. Hope that's okay.
Thank you, Helen. Can I ask you a quick clarification question? You used the words, the term clinically relevant.
Yeah.
And I was wondering if you could just explain a little bit about what that means, because the language might be familiar to everybody.
Yeah, it's so in particular in terms of MyCore or all the other measures, that clinical relevance. So there are bandings within WEMWebs, there are bandings within the Audit C alcohol intake questionnaire, which actually you can, if you look in the literature, it shows a certain degree of change on those score points shows a clinically relevant, actually making a difference in that person's life in a clinically relevant way to improve their quality of life. And the MyCall, we have worked out that there's a sensitivity on the scale. So any issues that people express on MyCall, say they're worried about, or they've got a particular issue with anxiety or a personal practical issue, we can show that it makes a difference in a clinically relevant way. It's a 1-point scale change on the scale.
Brilliant.
Thank you.
I think that might be some really important language just for us to reflect on how we might convey future evaluations. So thanks, Helen.
Great.
I'm now going to hand over to Carolyn, who's going to introduce our next speaker, I think.
Pnawn da pawb, afternoon everybody. I'm for those of you who don't know me, I'm Carolyn Wallace, Prescribing Research, and I'm here to co-chair and to introduce our next speaker, and that's Dr. Marcello Bertotti from the University of East London, and talking about a theoretically informed framework to analyse and evaluate social prescribing, a systematic map of theories. And I've been looking forward to this, Marcello, since I saw the title.
Thank you. Thank you for the opportunity to present. Can you see everything on the screen? Yeah. I must admit I found it difficult to make it. I made it as systematic as possible. But when you talk about theories, it's very difficult to find a systematic way to actually review information. But I'll have a good go, I guess. I will start from the aims of this, really. I mean, as Chris just said earlier, I mean, there is a very substantial growth of evaluation in social prescribing. And also, of course, reviews, and of course also the policy and the practice. The policies has gone ahead of evaluation in several by quite a while. I've seen in the literature. I mean, I hear social prescribing has been defined by Stevenson, for example, as a theoretical practice. What that means is really that there is, although there are a lot of evaluations of social prescribing, the theories underpinning those evaluations and the research on social prescribing is fairly limited. So what I thought, well, it's fairly limited. Let's have a look if it is really fairly limited. So we tried to look at it. And why do we need a theory? One might say we need a theory to guide our understanding, really, of a phenomenon in general. And the argument is that if you look at something from different angles, different lenses, you're likely to lead to a better and more complete understanding of social prescribing. One of the troubles, of course, of social prescribing is that it's not just one thing. Is actually a pathway. Is a journey of a person through a process. Is quite a lot. It's quite complex. So the aim really is here to. I just looked at social prescribing theories and concept, which. To the next one, yeah. So I basically looked at theories, concept in the literature through several databases, and identified about 137 records, basically, where there was a mention of theory, concept, and social prescribing, all in one document. But I was interested, really. We were interested in theories, in discussions, on substantial discussions of theories. So, and of course, one of the first problems is what is a theory, and is it complex enough? So we chose to use theory as an organized, coherent, and systematic articulation of a set of statements related to significant questions, which is general enough. And of course, there are different levels of theories. I mean, we don't have time to get into all of that, but I mean, I could go into all of that later on. So basically, after various sipping through the literature and so on, we came up with about 11 articles. which are basically these. And so one of the first problems was, well, how do we systematize this? How do we actually show it in a coherent way? So the first, looking at the literature, previous literature and stuff that I had done myself, to be honest, in the past, and also the work by Karen Husk and others, where they basically looked at social prescribing in different stages. Yeah, you know, the referral source, the link worker, and the delivery organizations, if you like, or the voluntary sector kind of actor. So you know, we got these three main actors: the GP, but it's not just the GP. Of course, it could be another referral source. It could be the schools, it could be camps, it could be secondary care, it could be some housing association. There are examples of that all spread across the country. But we decided to do it this way because it was more, you know, it was more kind of feeding into the existing literature on this. So we looked at, for example, stage 1 here, where GP consultation and referral, and really, in terms of the use of theories to look at this particular part of social prescribing, we could only identify the work from Hoggeston, Henry, I think is his name, and which uses this COM model. I mean, it would take too long for me to go all through through all the theories, but it's just to give a general idea. So this is a behavioral COM model, and the TDF is a behavioral approach, basically, to look at social prescribing. And in this case, he looked at GPs. Then the stage 2, as you can see, most of the literature and theories looking at social prescribing actually concentrated on the relationship between the link worker and the client, if you like, or service user. And there are primarily kind of behavior or drawing on psychology, self-determination theory. If you take, for example, the transtheoretical model of behavioral change, which underpins patient activation measure, for example, which Gina talked about earlier. And then there is social identity theory, which tell us about for example, the importance to belonging to a group. And actually, it's quite interesting, all of that, because the implication for a person to belong to a group, the importance of that, is that the implication for social prescribing is that in order for a person to maximize their access to social prescribing, it might be interesting or useful to encourage the link worker to get a person, to accompany a person to an activity and ensure that the person kind of access that group, that activity, but becomes part of that activity, because belongs to that particular group, feels as part of their identity, part of the identity of that group. So I'm not sure I explained it very well, but but anyway, we can. I'm writing a paper, so we might be able to read it if you're interested. So and then of course there's attachment theory, there's social capital, and of course there's asset-based community development, which belongs more to looks at social prescribing from the angle of the community development, community support, the voluntary sector, and of course this asset-based community development is Chris. I had to put it in because he is the chair. No, I'm joking. And finally, I found some theories like patient ecosystem management, for example, and the Christian system thinking, which are rather different in the way that we're looking at all of these. Christian system thinking actually is something that was done by University of Westminster. I think Marie is involved or was involved in that particular piece of work, actually. But I'll come to the conclusions because I'm worried about the time. And I have really there are many conclusions really I could draw. I mean, the analysis is quite complex, actually, and I'm still working on it. But three things that might be useful to point out. One is that is useful to think about social prescribing in those three stages. You know, the GP, link worker, and voluntary sector. But that is not the only way, because I think those three stages really look at the structures and the individual in those structures. While this ecosystem, for example, and critical system thinking, they look at the links between these actors, and they focus more the emphasis on the links. If you imagine these three actors and the links between them, the emphasis more on the links and the networks and the socialization between these actors rather than the actors themselves. The ecosystem in particular, but also critical system thinking. So this is a broad conclusion, really, but I'm still again working on it, really. And then the combining use of theory is quite interesting, because actually it really is true that looking at this from different angles does provide a much better understanding of social prescribing, and even using different psychologically informed theories on the three different stages might actually help us to identify a better way of way of understanding social prescribing in its complexity. And finally, salutogenesis. Although salutogenesis actually underpins a lot of the area as asset-based approaches, at least in philosophy, shall we say. You know, the emphasis on positive, the emphasis on the actual assets rather than deficiency, shall we say. Salutogenesis is not really treated much it's been talked about a lot, but just talked about, not really analyzed as a way to used as a way to analyze social prescribing. So, and there are probably a few other that could be brought in as well, but I'll stop there. Thank you.
Thank you, Marcello. That really interesting presentation, and I look forward to reading the paper, actually. But we now need to move on to the next presentation, and that's with Dr. Caroline Brett of Liverpool John Moores University. The effectiveness of psychological interventions used in motivating people to access and maintain participation in social prescribing and wellbeing activities. Another systematic review. Thank you.
Thank you, Carolyn. Can everyone see my slides? Okay, brilliant, thank you. This is wonderful. Thank you, Carolyn, for reading out the title. That saves me a few seconds in my talk. It's a very long title to this systematic review. So my name's Caroline Brett. I'm a health psychologist at Liverpool John Moores University, and I'm here to present some findings from a systematic review which was led by a colleague at University of Liverpool called Nadia van Ginneken, who's at the end there. She's a GP as well as was a senior clinical lecturer at University of Liverpool, and it represents a large team. I'm here representing a lot of people across our applied research collaboration, the ARC, Northwest Coast. So why do we do the systematic review? Well, we all know that social prescribing is really effective, or at least it can be, in helping people improve their own health and well-being. But it generally would involve some sort of change in people's behaviour, whether that's simply opening up the brown envelopes instead of putting them into a drawer, as a link worker famously told me. That's one of the things that she deals with a lot, is sort of benefits and those sorts of issues. Whether it's actually leaving the house when you haven't for a long time, whether it's going to a new activity, or whether it's just taking more control over your own health and well-being and managing your own conditions. So the problem is, because that involves quite a big change sometimes, some people actually never do it. They never engage with social prescribing referrals. We all know how difficult it is to change our behaviour. If anyone's ever done physio, we know how difficult. We know that the exercises are good for us, but we sometimes just don't do it. So that's an important thing that link workers need to bear in mind. And this might also exacerbate existing health inequalities. So the aim of our review was to identify pre-existing psychological interventions that we might be able to apply to motivate people to engage with wellbeing activities, including social prescribing. So although the review itself wasn't really focusing on social prescribing because it is fairly new, relatively speaking, what we were interested in was drawing all the evidence from other interventions in wellbeing to try and see what we might be able to apply to social prescribing. So we had very, very broad search criteria, and we did 2 searches. The first was in February 2020, and the second we did an update because we would like to publish this and they need to have a more up-to-date search. So we did a more up-to-date search in October of last year. We included studies that were quantitative, largely because one of the other members of the team was doing a qual review, so we wanted to pass things over to her for that. It needed to compare the intervention with some sort of suitable control, whether that be another intervention or usual care or something else, or the same intervention but without the motivational component. It had to target well-being, it had to contain a motivational component of some description, and there had to be some sort of measure of well-being or quality of life, or and some sort of measure of motivation. So in terms of the analysis, I coded the behavior change techniques. If you're not familiar with these, it's basically 93 techniques that are evidence-based to change people's behavior. And this list has been developed by an international consensus across behavioral science to identify things like goal setting or providing information about the consequences of your actions, action planning, giving instructions on how to do the behavior, that sort of thing. I also categorized the motivational components. We created a forest plot for quality of life outcomes because a lot of them use the same measures. And then mostly we did a narrative synthesis of the wellbeing and motivational outcomes and mediators. So this is what happened. We had about 14,000 records and then some more later on. We screened about 14,000 abstracts, excluded most of them. We full text screened 829 articles and excluded, again, most of those due to various reasons, which you can read there. And we've ended up with 42 articles. Trying to put these into categories was very, very difficult. So we worked with some public advisors who work in social prescribing, mostly as providers, not link workers. And we worked with a broader team and we identified different populations of interest. So we had 4 studies that looked at children with 1,200 participants. They had, in terms of behavior change techniques, they were between 0 and 3, so about 2 average. And then we had adults, we had young people with, again, a range of behavior change techniques, adults with cardiovascular risk factors like high BMI and so on. These ones had the most behavior change techniques, largely because they were focusing on lifestyle factors like healthy eating, physical activity, etc. We had adults with other risk factors, mostly socioeconomic, and that again had quite a range of behaviour change techniques. We had older adults, 3 studies. They had 7 to 8 behaviour change techniques. And then we had adults with specific conditions or long-term conditions, basically. So specific diseases, roughly 1,800, but you can see there's a large number there. That's because it was a very big population-based study looking at existing GP data. Around about 6 behaviour change techniques. There were 5 studies looking at cancer and 4 looking at cognitive impairment, which was dementia, and then 1 study of learning disability, which didn't quite fit in any of the other categories, so ended up there. We put them into some sort of framework. We went for the theoretical domains framework, the COM-B model, because it seemed to make sense to the public advisors as well as ourselves. So in terms of that, the interventions either focused on capability, improving people's skills or knowledge about the intervention and how to do the behaviour. Opportunity, so giving them information about how to do the behaviour, and then the one we were most interested in, which was motivation, which is things where we focus on thought patterns, emotions, goals, values to improve people's motivation to carry out the behaviour. Okay, I've got to rush through, haven't I? So in terms of the findings, in terms of motivational component, they were quite varied, from just giving people $25 for doing the intervention all the way through to very extensive motivational interviewing type one-to-one interviewing for many weeks. Oh yes, just to go back to Marcello's talk, ones that interventions that use that stages of change trans-theoretical model were generally more effective at changing motivation because they were targeting motivation. Wellbeing outcomes, I will brush through. Quality of life was in 17 studies. We had lots of different measures of well-being, and we looked at well-being mediators, things like social support, resilience, optimism, and coping, as well as psychosocial adjustment. Quality of life outcomes, the line in the middle is of no effect. So most were sort of around that, apart from a couple of studies which focused on disease-specific quality of life, and they targeted that disease and coping. In terms of motivational indicators, we had things like participation and engagement, stages of change, self-regulation, intrinsic motivation, inventory, behavioural intentions, and goal setting. And we looked at motivational mediators of things like self-efficacy, self-esteem, attitudes, beliefs, and knowledge, and of course, self-determination. So we actually incorporated a lot of the theories that were mentioned in the previous talk. Summary and recommendations in about 30 seconds, if less, 10 seconds. Motivation is really important for social prescribing. Interventions that are really tailored to the population, the individual, and their stage of motivation. So what's going on with them. So basically, like social prescribing, are probably more effective, so great. Intervention descriptions generally don't include enough information to really fully understand what's going on and what mechanisms are happening, and that's something that we really need to think about with social prescribing. And many studies didn't actually include any kind of measure of motivation or any kind of clear pathway to motivation or well-being, the why and how, which is what we're particularly interested in health psychology. And in terms of link worker training, I think a lot of these findings will be useful for understanding what link workers need to do in terms of improving people's motivation. Okay, so quick acknowledgements, huge study team, wonderful public advisors, and across 4 different institutions. So thank you. I will stop presenting. Oh, there we are.
Yeah, Caroline, thank you for that. And we'll go quickly on to the next presentation. And unfortunately, Dr. Bryony Porter is not able to join us, but we're very pleased to see that Kate Wood has stepped into this presentation at the last minute. So hopefully we've got your slides ready and ready to present. If we could. No? Lovely. Thank you very much. And thank you, Kate.
So good afternoon. My name is Dr. Kate Wood, and I'm presenting on behalf of my research colleague, Dr. Bryony Porter, Senior Research Associate at the University of East Anglia. I'm pleased to be part of Bryony's research team, and we're looking at loneliness, mental health and well-being, an acceptability and feasibility study of UK men's sheds. It's funded by Network Plus Projects at UCL. So I'm going to be presenting a brief overview of some findings from interviewing men's sheds members, where they related some of their perceptions and understandings of social prescribing. So the background, what are men's sheds? They're spaces such as workshops, sheds, warehouses or church buildings used as making environments for woodwork, metalwork, craft and other DIY activities. Members are known as shedders, and they often find it hard to communicate face-to-face, but through the sheds they're enabled to talk shoulder to shoulder whilst their hands and minds are busy doing other tasks. There's a global movement of men's sheds. It originated in Australia, and we now have over 600 sheds in the UK, supported by the UK Men's Sheds Association. We surveyed 93 shedders and interviewed a subset of 21 to talk further. So next slide, Abigail, please. So joining a shed, there are different routes to joining a shed, and we found that informal referrals through wives or relatives were the most common. There were some formal referral experiences through local providers and social prescribers. Most often, joining a shed was associated with a significant change in personal circumstances, for example, bereavement, retirement, physical or mental health, or moving location. Sheds provide a space for mutual exchange of skills, where the inadvertent consequence of the shoulder-to-shoulder approach within a space where like-minded people, often very different to each other, but usually men, offer each other support. Next slide, Abigail. So if we look at social prescribing and what the shedders told us when we interviewed them, there was some social prescribing successes where referrals had gone well and they'd had lasting impact on individuals and the shed. However, there were other examples where things had not gone so well. Where things worked well, there was an existing relationship and a good understanding between the shed and the local prescriber. Some successes were examples of veterans and a young adult with autism who learnt skills and gained confidence to find employment. Another shedder who was crafting a coffin enabled a link worker to gain an informal talk to raise issues around end-of-life care plans. So next slide, Abigail. A few concerns were raised among the shed community about the potential impact of social prescribing on spaces that they were rightly proud and protective of. Most sheds are run by retired volunteers who already have big responsibilities. They had grave concerns about greater responsibility from referrals in regard to health and safety and additional procedural burdens. There's a fear that referrals may impact upon the dynamic and unique nature of individual sheds, and that shedders may feel overburdened with these initial needs. So a phrase, we care, but we are not carers, was a resounding view across the interviews. Shedders care deeply about their sheds and their members, but they're not professional service providers. The next slide, Abigail. So, concluding remarks, sheds offer a unique space where people, particularly men, have a sense of value and purpose. They can learn and share new skills while inadvertently finding and offering support to each other. There's a huge potential for social prescribing. However, our research highlights a need for a sense of caution that we do not destroy the very special attributes that sheds offer. So to conclude, where it works best is where there's an existing relationship and a good understanding between the shed and the local prescriber. So on behalf of Bryony, I would like to thank the research team and the funders of the study, and thank you all very much for listening. Finally, Bryony would like to invite you all to attend an online event with shedders and social prescribers from across the UK next Tuesday from 10 o'clock to 11:30, and the next slide has some finer details of that. So thank you very much for listening.
Oh, thank you very much, Kate. And I think you'll all agree that we've had some fantastic presentations this afternoon, even if you've got your bags in the hallway ready to leave. We've talked about evaluation, systematic review, theory, outcome measures, and some very, very interesting social prescribing interventions where they've demonstrated significant results and one in particular translated into potential cashable savings. I'm sure there must be some questions. I can see a lot of conversation being happening in the chat. But there must be questions out there that people would want to ask. I've got one in particular which I'd like to kick off with, if that's at all possible, and it's a question about how you first engage with colleagues when you are undertaking an evaluation, and that's a question going to Gina and to Kate and to Caroline. To all of you.
I could go first.
Yes.
That's such a good question, and what I've taken lessons from is the lessons of social prescribing themselves, right? Which is to find out what it is that the program deliverers and the link workers, what it is that matters to them and what they really do want to know. And very often a part of that is that they need to be accountable to stakeholders. They need to be able to put business cases together. And other parts of it, though, are that they, end up in discussions realizing that they also want to be accountable to themselves. They want to be accountable to the people that are receiving social prescribing. They want to be accountable to the people that they're working with in the field and in the sectors and things like that. And really, evaluation is a way to reflect on that, to refine, to continue to improve, and to give people a voice in what's happening. And when people understand that, they are much more willing to participate in evaluations, both the actual recipients of the services as well as the deliverers who also need a voice and can have a voice. It really helps morale. It helps to have these groups represented when the evaluation is designed. And it also helps to have continual discussion about it, if possible, throughout the entire delivery, so that it's really clear how it can be used to refine delivery, to allocate resources and make adjustments that really make people realize that it's helpful and informative. And that's the real goal of evaluation at the end.
Kate, have you got anything to add to that?
No, our study was really a kind of bottom-up study, if you like, actually looking at recipients of voluntary interventions, not necessarily part of formal prescribing yet. And I think the overarching caution that came from our interviewing of shedders was not to lose the heart of what had developed through these voluntary links by formalizing it, that there could be some sort of destruction of what has been created through it. So I don't think we're quite ready yet for the evaluation phase. We're still in that inception of looking at sheds to become a part of formal social prescribing.
Thanks, Kate. And Helen, do you want to come in?
Yeah, I was just going to say, a lot of the times in evaluations of social prescribing, we find that there's a real burden for people to collect data, and there's a hell of a lot of outcome measures taking a lot of time from the consultation that should actually be, used to help people, and just collecting outcomes for outcome's sake, maybe that don't even get a follow-up data matched with it, and it's a real burden that we should really push back on and say, no, thank you. Why are we collecting this? And be really pragmatic. The data we collect is precious, and the people that give it to us, that they should be respected. So I think we need to be really careful that we shouldn't just bandy this need for data around. It's precious. I just wanted to say that.
Yeah, it's a very good point, isn't it? Because if we overburden people from an evaluation perspective, they'll never ask us to work with them again. And that's apart from the fact that they have got precious time. Anybody else want to ask any questions?
I was going to introduce a reflection from the chat.
Okay,
Carolyn,
yeah,
actually,
please do. You carry
around how there's an interesting discussion going on between Marcello and a few people about the usefulness of theory, and maybe there's something about, do we need to raise awareness of theory amongst link workers so they understand the theoretical underpinnings of why they're doing it. And I think sometimes as academics, we worry that theory kind of isolates the general public, and potentially policymakers. But I was also reflecting on the discussion we had in the previous session about the evidence base always gets criticised, but actually there is some really strong theory behind why we do social prescribing. And I was just wondering whether Marcello and any of the other presenters had a thought about how do we make the policymakers and decision makers more aware of the theory and more comfortable with using the theory to justify the decisions they make.
Marcello,
do you want to respond?
Well, we do attempt to kind of we teach theories, some theories kind of social capital and asset-based community approaches when we deliver training. And so we try to do it that way, but a lot more could be done, particularly because it is true that social prescribing is primarily, psychology. Kind of, it draws on psychology primarily, because the relation between the link worker and the service user is particularly important. So, and is primarily a psychological kind of interaction. In terms of, it's interesting that actually it would be worth talking about realist evaluation at this stage, because I think realist evaluation has an emphasis on creating a program theory, actually, which is something that is kind of done by all the stakeholders together, from the service users to the researchers to commissioner and so on. So I think that is quite an interesting way forward for me, and indeed I haven't used it, and I'm using it now in 2 projects. So. It is very interesting way forward for me, and it would kind of really kind of clarify the theory going forward, and it can be also to some extent targeted to the groups that you are to the target group, essentially. Yeah, so I'll stop there.
I think that's a really interesting point, Marcello. I've always found that using realist evaluation has always been readily accepted by commissioners, to understand how things work. It's in whichever area of research I've been working in. I think it was Tim next.
I think so, yes.
Thanks. I'm not quite sure how to formulate this, but in terms of sort of social prescribing as part of a system, it seems to me we don't evaluate that particularly well. And I've spent a lot of my career meeting people who say, if only I'd found out about this 5 years ago, my life would have been much easier. And that is one of the core functions of social prescribing, that linking what's already there together. And I think we almost should be starting from a basis of saying we're actually wasting a lot of the stuff that's already there because we're not linking things together. But that's not evaluated, it seems to me, and yet it's an absolutely fundamental argument for doing it, and also a fundamental argument for getting commissioners to pay for it, because they're already paying for some of the stuff that people aren't getting to because no one ever told them it existed. So yes, that's my point.
So if I could actually, I'm sorry, Chris.
Sorry, go on, no, Gina, you go first.
Go on, Gina.
So just to weigh in on a couple of the things, I absolutely agree with what both Tim and Marcello have just said. Part of the conversation that I believe is so important to have around evaluation is the question of what is the theory of change here? How are we meant to go from a chunk of programming on paper with some money and some people involved to these impacts that we believe social prescribing can and will achieve? Some of them indeed being on the sector and involved with linkages and things like that. And it really helps to ask the stakeholders of a particular program, what is it later on if someone came up to you and said, look, I have this program to tell you about, it was a huge success. What would they tell you that would convince you that it was a huge success? What would you need to hear to know that this program not only was making a positive difference, but it was the thing that made the positive difference in the lives and the communities where positive changes occurred? We actually, my team is starting to evaluate some of these connections, and it's hard because the easiest way to do it is to ask people which connections they made and how that was helpful, and that does create another burden on the person who's being, getting the social prescribing service to keep track of these things in ways that is not their job.
Thanks, Gina. Chris, do you want to come in and
I was just going to say, I think those reflections about the system are really important, and maybe we spend too much time worrying about outcomes, don't we, and not enough time thinking about the system. And I'm involved in a team that's evaluating the government's national green social prescribing programme in England at the moment, and we are trying to take a systems approach there to try and do that work. But it's quite challenging, and policymakers still want to know about outcomes, don't they? And we have that tension as evaluators. Well, give the outcomes evidence, give the systems evidence. So it's be interesting to see where the movement goes over the next few years regarding evaluation.
Can I come in just to say that just a plug from the Wales School for Social Prescribing Research, we're just about to have a paper published on evaluation methods in the BMJ Open, and we'll feed it through to everybody through the network in the next few weeks when it comes out.
Brilliant. We are almost out of time, aren't we? I don't know if there's any final questions. If there isn't, we have been asked by the organisers to remind everybody that there is another session at 4:10, and it's going to be all about kind of co-producing priorities from the conference. So if you have got time to stick around for that, that'd be really, really welcome, I think, to kind of cap the 2 days off with some kind of collective thinking. But if there aren't any more questions, I guess we can just kind of thank our presenters again for some really thought-provoking and interesting presentations, and hope to see you all again soon.
Yes, thanks everybody. Diolch pawb.
Thank you.
Thank you.